One of the most difficult things that I have to ever say to a parent is your child has one of the fetal alcohol spectrum disorders. And that's because I understand the difficulties that these children will face in their daily life, at school and at home, and also the difficulties that they'll face in the future. And one of the most distressing things about these disorders is that, of course, they're potentially preventable. If you don't drink alcohol in pregnancy, you won't have a child with one of the fetal alcohol spectrum disorders. Clinicians really do need to know about the potential harms of alcohol use in pregnancy, including fetal alcohol spectrum disorders. We all know we've got a drinking culture. We're amongst the highest consumers of alcohol in the world. We know there's a binge drinking culture in teenagers and that rates of drinking, and particularly risky drinking in girls, have increased tremendously. We know that about 49% of pregnancies in Australia are unplanned, plenty of opportunity for inadvertent exposure to alcohol, and we know there's alcohol use in pregnancy. We know that young women are targeted by advertising. This is just one example of an ad that appeared in the Sydney Morning Herald, advertising low-cal vodka cruises to appeal to women, with the free offer of condoms and a pole dancing kit if you bought enough of these. We know that kids are drinking a lot, and we know that there are even games online. There's one called Let's Get Wasted, which is being used by thousands and thousands of teenagers. So you can pick a drinking partner, and even if you're by yourself at home, you can play this drinking game until you get drunk. We know that there's alcohol use in pregnancy, and alcohol use is no higher in Indigenous than non-Indigenous people, which is a bit of a misperception. But Indigenous women, some Indigenous women, and particularly those living in adverse conditions in remote settings, drink in a different drinking pattern. In some surveys, 20% of women have said that they've binged on at least one occasion during pregnancy. So binge is variously defined as 5 or 6 drinks in a single sitting. So why does alcohol harm the fetus? Well, we know that the maternal blood alcohol level is almost instantaneously transferred to the fetal blood. We know how we feel after a couple of drinks. Imagine what this is doing to a fetal brain. We know that alcohol's a teratogen. That's not in dispute. It's been known for centuries. And we certainly have very good evidence also from animal models of what it does at the subclinical level as well. And the effect on the fetus depends not only on the dose, the amount of alcohol drunk, how frequently it's drunk, when it's drunk during the pregnancy, and a whole range of maternal and fetal factors. So if you're a clinician trying to advise someone about the risk of drinking during pregnancy, it's really pertinent to say to them that the individual risk is very difficult to determine. My body weight, my metabolism, my alcohol dehydrogenase genes, my pre-existing illness will all affect the way in which I metabolise alcohol, and hence how high that peak blood alcohol level will be. A PhD student of mine, Liz Peden, has recently done a survey of women of childbearing age from around Australia and found that 1/3 of them were unaware of the adverse effects of alcohol during pregnancy. Furthermore, 20% were quite tolerant of its use during pregnancy. So they were given a little scenario of a woman getting drunk in a pub. 20% said, that's fine, that's up to the women. And what we found was we then asked these women to identify had they drunk in a previous pregnancy and would they drink in a future pregnancy. And 1/3 of them said yes, they would drink in a future pregnancy. And we found that this intention to drink was strongly associated with attitude, not knowledge. So often these were highly educated women who knew that alcohol could cause harm, but if they had a tolerant attitude to alcohol in pregnancy, then they indicated they'd likely to drink. They were more likely to drink if their partner drinks, if they smoked, and if they were currently drinking at harmful and risky levels. So these are people who are really at risk, and we should try and identify in our practices. Indigenous women, in fact, knew quite a lot about alcohol use in pregnancy when we did some focus group work in Western Australia. And really the key to these women living in disadvantaged remote communities is the stress that they suffer on a daily basis, both the historical trauma that they've suffered, but the ongoing disadvantage which is leading to their stress. So it's very important not to shame and blame these women when we're talking about alcohol use in pregnancy, and to understand why people might be drinking. We also did a survey of health professionals, over 1,000 health professionals in WA. These 700 or so regularly saw pregnant women. And what we found was that only 45% routinely asked about alcohol use in pregnancy. In fact, 12% didn't ask. Clinicians were often worried about causing fear or anxiety, about stigmatising women. But in contrast, we have some evidence that women actually want to know and want to be advised. At the time, the current guidelines were the 2001 NHMRC guidelines, and very few clinicians knew what they contained. So I'd be interested to know how many of you know what the recommendations are in the current 2009 guidelines. What we did also find from Liz Peden's survey was that, quite contrary to health professionals' perception that they didn't want to upset people and that women would be afraid of being asked, women say that health professionals are the best source of information about alcohol use in pregnancy, and you can see these very high figures. Over 90% said health professionals should ask, they should advise, and furthermore, they should advise women who are pregnant or planning pregnancy not to drink. So women are quite receptive to this advice. And in fact, women who are pregnant want the very best outcome for their baby. Ken Jones is a dysmorphologist from the States who first described fetal alcohol syndrome in the English literature only in about 1973, and hence for many of us this was not a big component of our medical or allied health or nursing curricula. The 40th anniversary of this was in 2013, this description in The Lancet, and Ken said, wouldn't you have thought that by now the message would be getting through? But sadly it's not. What he described was fetal alcohol syndrome, that is, babies born to alcoholic mothers who were small, they had a funny looking face, they had birth defects, and they subsequently were slow to learn and develop. And we now realise, however, that there's much more of a spectrum than just fetal alcohol syndrome. And what we now are seeing a lot of is neurodevelopmental disorders, children with impairment of CNS function who don't have the physical features but still have all the functional problems that a child with fetal alcohol syndrome has. And this relates to the timing of the exposure. So of course you're going to get facial abnormalities and structural organic abnormalities only if there's exposure during that period of embryology in the early part of pregnancy when these structures are forming. But of course the brain is rapidly developing throughout the second and third trimesters of pregnancy, and we know that alcohol disrupts neurogenesis, neuronal migration, the development of neurotransmitters. It can cause structural damage to the brain, it can cause a small brain, and hence a brain that doesn't function. And of course alcohol is related to stillbirth, prematurity, miscarriage, and a whole range of birth defects. We really need to reiterate that actually what we used to advise in the past, no alcohol in the first trimester, really doesn't apply. It's got to be no alcohol throughout the pregnancy. This is a child, this is not the child, but this is the case history of a child that I saw recently in my clinic in Sydney. 3-year-old boy, born to an alcohol-dependent mother who was drinking on a daily basis, large amounts, and in fact I think she subsequently died from her alcohol dependency and complications. This baby was born preterm, low birth weight, was very irritable, fed poorly, had a seizure soon after birth. He was then slow to develop speech and motor development. He was having difficulty learning, couldn't recognise any colours, had limited language. He had a squint, he was emotionally labile, and he was socially inappropriate, very over-friendly, would go off with anyone, no stranger danger. He had attention deficit problems, he was hyperactive, he was climbing onto roofs and jumping off, running out onto roads, running away from his father, and had great difficulty taking on any complex instruction. So problems with executive function are characterised by kids or people who can't plan or execute complex tasks, and he would repeat mistakes. So each morning he'd put his clothes on top of his pyjamas and be corrected but do the same thing the next morning. And as many of these children, he was labelled as disobedient. He wasn't being disobedient, he really just didn't know any better. So alcohol really, because it damages the brain, can cause a whole range of problems. Structural damage to the brain, I've mentioned, CNS dysfunction. It can cause growth failure. It can cause birth defects and facial dysmorphology. But the really difficult management problems are the behavioural, learning and developmental problems. And we can categorise, as I've said, these conditions into fetal alcohol syndrome or partial fetal alcohol syndrome, which are associated with physical anomalies of the face, plus or minus birth defects, and neurodevelopmental disorder with alcohol exposure. And I call it that rather than alcohol-induced neurodevelopmental disorder because, as we all know, these children may have many other factors in their life, including early life trauma, which might be contributing to their developmental problems. It's very difficult to attribute everything to alcohol if you don't have the physical features. The other point to say is this is a diagnosis of exclusion. Obviously other syndromes need to be excluded, genetic and other disorders, injuries, seizure disorders, meningitis, anything that can cause significant brain impairment. So really the first phase to this making a diagnosis is establishing alcohol exposure. And we use the Audit C, which is a simple three questions about frequency, binge drinking, and the amount drunk. And you can see you can get a score. The score of 0 to 3 is low risk, 4 to 5 moderate risk, and 6 or more risky or high risk drinking. This certainly was recommended by the government in life scripts for GPs till recently. I don't know whether they're still recommending using the Audit C. So that's the first thing, establishing alcohol exposure. Sometimes this is very difficult to do. A lot of the kids that I see in clinic are kids in foster care, so there are not good records. We have to get the Department of Community Services to try and chase that exposure record. But often you can get corroborative evidence or even observational evidence from people living with the woman or who've known the woman. You can get evidence that the woman's had alcohol-related admissions or a diagnosis of alcohol dependency, etc. The second thing we look for then is these characteristic facial features. Children, if the brain is affected, the optic nerve is affected, then the eye might be small and the eye opening, the palpable fissure, can be small. We can measure that and plot that against normal charts. You can see that there's mid-face hypoplasia or underdevelopment in response to alcohol, so you get this thin upper lip and what's called the flat filter from the area between the bottom of the nose and the upper lip. And you can see the contrast in the child with and without fetal alcohol syndrome there. And we've got these lip filtering guides from the University of Washington, which we use to evaluate the face clinically. The eye can be measured by calipers, which I think are a bit dangerous, or a plastic ruler, which is much easier. But what we use is we take a digital photograph, we put it into some software that we've got. We're able to measure the various components of the face, including the volume of the lip, and the software will give us an answer as to how this falls. And what we're interested in is abnormalities 2 standard deviations below the population mean. And you can see these facial features hold whether you're looking at a Hispanic, Caucasian or Afro-Caribbean child. And similarly, we're doing a lot of work with kids in Aboriginal communities, and the features hold there as well. I've mentioned the central nervous system abnormalities. In extreme cases there will be microcephaly, and you can see this extreme case on the right of a child with fetal alcohol syndrome and the difference in that size of brain. You don't have to be a brain surgeon to know that those connections are disrupted and that brain will not work well. But in the absence, and we do see structural abnormalities on imaging as well in some cases, but it's really the functional problems that are of most concern. So children often have neurological signs, they may have a low IQ, they may have learning problems, problems with their memory, problems with executive functioning, I've mentioned, speech and language development. ADHD is very common, and presumably some of these kids are getting a diagnosis of ADHD or autistic spectrum disorders or oppositional defiant disorder or whatever without people actually realising that they're symptomatic of an underlying brain injury. These kids often have problems with adaptive behavioural and social skills, and I've mentioned problems at school in academic achievement. What do we know about this condition in Australia? Well, there's actually quite limited information. This is a study we did back in 2001 to 4, where we emailed all paediatricians every month through the Australian Paediatric Surveillance Unit, which is a mechanism to study rare diseases, which has now been running for about 21 years in Australia. So every paediatrician gets a little card they have to tick, have they or have they not in the last month seen a newly diagnosed case of fetal alcohol syndrome. So remember, this is just the tip of that spectrum. And we identified 92 cases using quite strict criteria. Half of these kids had a small head, and many had been evident at birth, the small heads. However, few had been diagnosed at birth. 64% of the kids were Indigenous, 60% lived in out-of-home care. And what was really distressing was half of these kids had a sibling with fetal alcohol syndrome, so we'd missed those opportunities for prevention. Most of these kids had high-risk alcohol exposure, so again, we're probably just dealing with the tip of the iceberg, and 24% of them had a birth defect aside from the facial abnormalities. So these are the sort of birth defects: significant cardiac, skeletal, renal, ocular defects, cleft palates, so really quite a wide range. But they also had developmental and mental health problems, problems with language, motor delay, behaviour, hearing, vision, and anxiety, depression, and conduct disorders. And self-harm is a big component in these kids. Colleen O'Leary's done a lot of work in Western Australia using large data sets where she's been able to link the birth and the child and the educational and other outcomes. And she's found quite clearly a dose-related effect of maternal alcohol intake on stillbirth, on low birth weight, on prematurity, on rates of birth defects, on cerebral palsy, which is an interesting one, and on language delay. So a lot of these things were sort of assumed because they were described in cohorts of kids with alcohol exposure and fetal alcohol syndrome. But this is really proof that in Australia there's a clear association between alcohol and these adverse outcomes. But we do believe that these conditions are undiagnosed in Australia, and this is going back to our survey of health professionals in Western Australia. We asked them about the essential features of fetal alcohol syndrome. Again, just the tip of the iceberg. Only 12% of them were aware of all of the features, although they were aware of some of these individual features. Also, they were reluctant to make a diagnosis. 53% of them said they were worried about stigmatising parents and families. About a third said they had suspected but not actually diagnosed fetal alcohol syndrome. 4% said they were convinced of the diagnosis but hadn't recorded it. And 66% said they didn't feel very well prepared to deal with fetal alcohol syndrome. So we developed, as a result of this, quite a lot of resources. These should be available on the Telethon Institute website. So if you just Google Telethon Institute for Child Health in Western Australia. And we then distributed these to all the health professionals in WA and redid our survey and found a significant increase in knowledge and confidence in dealing with these issues, and particularly in asking and advising about alcohol use in pregnancy. June Oscar, who's a colleague of mine who works in Fitzroy Crossing, is an Aboriginal elder and became aware of the potential for fetal alcohol spectrum disorders in her communities. She described fetal alcohol spectrum disorders as a tragedy that somehow transcends other aspects of grief and trauma. Here is innocent young life, the future of our people, our culture, our language, knowledge about the magic creation and laws of our country, being born into this world with brains and nervous systems that are so impaired that life for that person from birth to death is cruelly diminished. June has subsequently called this a humanitarian crisis, and she invited myself and others to go and work in the community, and we've now been working in the Fitzroy Valley for the last 7 years looking at this issue in Aboriginal children. I really do want to stress that this is not a problem in Aboriginal people. It's a problem throughout our society, but of course if you're looking at a remote community where there's been high-level alcohol use for decades, then you're going to see clustering of this condition. And this is just one of the nieces and nephews that June looks after. It's all the grannies my age who are looking after all these kids for their own children and their nieces and nephews. So it's placing a huge burden on these societies. So what they did was develop a strategy to address fetal alcohol spectrum disorders with the 3 themes of diagnosing, supporting families and kids, and of course prevention. They invited us to come in, and this was one of our PhD students, James Fitzpatrick. We developed a questionnaire and identified all children born in 2002 and 2003 in these 45 very, very remote communities, and asked them a lot of questions, reviewed their medical records, and one of the questions, of course, was about alcohol exposure. And to do this, we photographed the available grog. And I think when you're taking a history about alcohol, it's very important to establish what people are drinking and what is a glass. I mean, many of us have a glass of wine, which is really 3 units of alcohol, 30 grams of alcohol, not 1 unit. So it's important to know what people are drinking, and we use the Audit C to document this. What we found was that half of the women didn't drink at all, and that's the blue, or they drank at very low risk levels. The other half did drink. 55% drank during pregnancy, 88% drank during the first trimester, 53% drank throughout the pregnancy. Mostly they drank full strength beer from cans, but of the women who drank, you can see on the right side of that graph, the yellow bit, the majority of them drank at high risk levels. So what does that mean? Well, if you look just at the right-hand side of this graph, that's 10 or more drinks on an average day, and the frequency is either once every week or 2 to 3 times a week, or in the far column on the right, the black one, daily or almost daily. So 10 or more drinks on a very frequent basis in these 55% of women who drank. In stage 2 of our study, we took a multidisciplinary team, a physio, a psychologist, an OT, a speech therapist, paediatricians, eye and ear doctors, to not only collect data but to provide a service for these children. And we did a competent assessment over about a 4-day period per child. And we had to use a variety of different methods. For example, we used the UNIT, which is a universal non-verbal test for testing IQ, because these children have so many different languages. When we were testing speech and language, we used a local community navigator to help us administer these tests in the local language. So I think the point of this is that when you're testing these kids, the tests that you use, whatever domain of function you're testing, will have to be appropriate for the age of the child and culturally appropriate as well. And what did we find? Well, not surprisingly, we found very high rates of fetal alcohol spectrum disorders. We have published that 1 in 8, or 12% of these kids, have fetal alcohol syndrome. We know that an additional proportion have neurodevelopmental disorder associated with alcohol, meaning that overall about 1 in 5 of these kids in these 2 primary school age groups are likely to be affected by alcohol. They have behavioural problems, physical problems, growth, mental health, motor, IQ, memory, academic, all the things that I've talked about. They have the whole gamut. And we made well over 400 referrals for these 110 children to a range of services. So what problems did they have? You can see half of them had microcephaly. They had neurological abnormalities and again, all of the things that I've listed. And can you imagine teaching a classroom if you've got a proportion of kids with totally disruptive behaviour, sensory problems, attention problems, aggressive behaviour? It's almost impossible to teach. These children certainly, the children with fetal alcohol spectrum disorders scored lower than the others for attention, academic performance, adaptive function, social skills, post-traumatic stress disorder they had more problems with cognition, a lot of problems with aggressive behaviour and oppositional defiant sort of behaviour. And critically, and these data were taken from the Achenbach Child Behaviour Checklist and the teacher report form, 14% of these kids with fetal alcohol spectrum disorders were talking suicide. 38% of them were aggressive at school and at home, and you can see the comparison in the kids without FASD. So remember, these are kids 7 to 9. And of course, as we've watched them over the last 5 years get older, the problems change, they don't get better. So they get into problems with accessing pornography, sexual problems, psychotic episodes, drug and alcohol use themselves, academic failure, and importantly, contact with the justice system. And I think that we need to look at our juvenile justice system, both in Aboriginal and non-Aboriginal communities, and try and identify which kids are actually incapable of giving evidence and understanding what's right and wrong. Because I'm sure that, particularly in Indigenous communities, a lot of the kids in juvenile justice could be kids with impairment due to fetal alcohol spectrum disorders. And I do think we need to keep in mind that this really is a human rights issue, that every child has the right to survival and development, and also to the resources to enable full development. Now, we're dealing in some of these communities with inadequate access to education and health anyway. So you add in these problems of kids with chronic complex disorders, and it's very challenging. But I've mentioned before that fetal alcohol spectrum disorders are a lifelong sentence, and this particular study that followed 415 kids to adolescents found that because of their disrupted education, there were high rates of unemployment, problems with the law, drug and alcohol abuse, sexuality, and only 10% of them were able to live and work independently at the age of 21. But we do need to not be too pessimistic about this, that a lot of these kids do quite well. The IQ is not necessarily low, and with appropriate nurturing, certainly in Canada, we go to a conference where a lot of families attend, and these kids really have been enabled to full their potential. One of the problems clinicians have is uncertainty of how to treat these kids, and there is no magic bullet. Liz Peden's done a systematic review, and although we identified almost 6,000 articles on fetal alcohol syndrome, there were only 8 randomised trials providing significant information about specific treatments. Really the key to this is to identify the specific needs. If a child's got speech problems, they need a speech pathologist. If they've got motor problems, they need a physio, etc. So, and that's why the assessment is so important, not only to fulfil the diagnostic criteria, but to help the child. So what is being done on fetal alcohol spectrum disorders in Australia? We've got guidelines, and they advise that for women who are pregnant or planning a pregnancy, not drinking is the safest option, and we all need to be promulgating that message. We've developed recently with the Department of Health and Ageing some resources for health professionals. You can go to the Department of Health and Ageing website, look up alcohol, and you'll find, or women want to know, and you'll find some videos and pamphlets and information sheets for health professionals. We're currently being funded by the Department of Health and Ageing to develop a screening and diagnostic tool, really to help guide clinicians through what they should be looking for and how they can make the diagnosis. I've had some pilot funding for a clinic in Sydney, and more recently there's been an announcement that the government will provide, New South Wales government will provide money for a clinic, which will also help in training other health professionals. We've recently had our first congress and hope to have another one in Australasia. And as part of our Fitzroy project, we've made several films, including this one called Tristan, which describes the life of a little boy living in Fitzroy Crossing with fetal alcohol spectrum disorders. And this we even took to the UN, to the Permanent Forum on Indigenous Issues, because this is a problem for Indigenous communities who've suffered historical trauma throughout the world. Aboriginal people really have been leading the way for a long time in this. They've recognised it, I think, because it's more obvious, it's more concentrated, and they have been providing a lot of education for communities. Elizabeth Russell, amongst others, have written books about their experience as a birth mother with affected children. The Foundation for Alcohol Research and Education is trying to reinforce that actually fathers are very important and try and encourage fathers to pause with their drinking while their partner's pregnant. And again, that's a message that we can promulgate. If you've got anyone you're concerned about, the National Organisation for FASD provides information and advocacy for parents. We have got a proposal developed for a national plan for fetal alcohol spectrum disorders, just to give a framework. We really need to encourage continuation of these alcohol restrictions, particularly the community-led ones. You've all heard of the success of the restricted opening hours in Newcastle and in Sydney and King's Cross, and again, as health professionals, we need to support these endeavours to decrease access. Labelling. We do need labelling. At the moment it's voluntary for the alcohol industry. We know that they're not labelling bottles, and if they do it, they're minuscule labels. We really need to mandate this, so at least people can be provided with the information that alcohol may harm the unborn child. The College of Physicians is currently revising their policy on alcohol, and there's recently been a national inquiry into fetal alcohol spectrum disorders headed by Sharman Stone. This inquiry reported on the need to prevent, particularly diagnose and manage these conditions, and called it the hidden harm, because of course in much of society this probably is hidden. The federal government, following this report, announced $20 million for a national approach to FASD, but the government changed soon after and it dropped to $9.3 million, and again we haven't seen much of that money yet. But I have been charged with leading a national technical network to look at what are our priorities and what sort of framework might we have, acknowledging it won't be funded, but really just making some sort of strategy. So I think we've got to remember that everyone has a say in the alcohol debate except the fetus. We really do need to give voice to the fetus. And as clinicians, we must ask about alcohol use in pregnancy, assess the woman's willingness to change her behaviours, provide advice and a brief intervention, but if necessary, refer to specific drug and alcohol services. We really need to assess the baby and look for those red flags and refer to a paediatrician or a child development unit for assessment. We really do need to advocate for services and for support for these families, and of course prevention. And that really needs an all-of-government approach. So fetal alcohol spectrum disorders are everyone's business. Prevention, I think, is the key. When you see these kids and the amount of difficulty they have, really realise this needs to be prevented rather than managed. And thank you for your attention.